Okay, start taking your seats. Chase people up from their lunch. Here's our Mentimeter results coming up here. Can you wind back up there to the beginning again, Steve? Nice, nice, yeah. Great, good. Who's enjoying themselves? Hey! Who's not enjoying themselves? Yeah, that will sort you out later. Great. This is always a tricky one after lunch, isn't it? A pool, no, I'm not a draw enough. We could have another joke. Yeah, joke. Well, a joke, right. Wait till it comes. No joke. How many IMF economists does it take to change a light bulb? How many IMF, International Monetary Fund economists does it take to change a light bulb? None. Free market will do it. Ta-dum. What's that? Have you got any suggestions? Come on, take your seats, folks. We've got cascading Mentimeter running through Mentimeter as we settle down. Well, I don't know about you, but I'm really enjoying myself. I'm just chatting on now. Are we ready to start? Is anybody else downstairs? Come on. Warren and colleagues, in a minute. Warren's got the hard slot here, eh? Just after lunch, Warren. Warren will spice it up. Up here on Mentimeter, right, we'll start. Up here in Mentimeter, there was stuff, I'm interested in the equality of voice and voice thing, which was something I was talking to people over lunch, actually. And there's something fascinating about voice and power of voice and equity of voice. And it seems to me that in this wealth creation world, we should be moving to a situation where there is genuine equity of voice, and that the citizen voice has to have a bigger play, because let's face it, the NHS, the health system's hierarchical, isn't it? Some have bigger voices than others. So we're talking here about a recalibration of voice, and perhaps even a re-democratisation of the NHS healthcare system. What does democracy really look like in a wealth-creating health system? How does genuine voice and power and control come back to the citizen and the user of that service? Does one think that the reform plans genuinely grapple with questions of democracy and power and control and voice? Does the devolution model we have, does that genuinely dig deep into questions of democracy, voice, control, and power? Or is it just a shuffling of the deck chairs to retention of power, but in different places? I don't know. But I do know that from where I sit at the Democracy Collaborative think tank that I work for, these questions are fundamentally important about how we improve public services and create an economy that truly works for all. Voice, power, and control. And we're talking about that a lot. but is the operating system we fit within dealing with those questions of voice, control and power. I'll leave that with you and maybe get a bit abstract. We can get into political philosophy over coffee break. Right, enough of me. Let's pass over now to towards a cross-sector health creating neighbourhoods health service. And first we're going to hear from the Warren Heppolette, who's going to introduce the session, and we'll run this for about half an hour. Warren, the floor's yours.
Thanks, Neil.
Give Warren a hand, come on.
Thanks, Neil. And I am going to be joined by 4 fabulous colleagues who've been part of a piece of work that we've been doing under the auspices and convened through the Health Creation Alliance that we'll say a bit more about. The first thing I'm going to say is we are bang on time, aren't we? Neil McInroy runs a really, really tight ship. Yeah. So this is quite special, being on time in the afternoon in an arrangement like this. So I'm going to, there are mics on there, aren't we? What I'm going to do first, before we get into it, I'll introduce me, and then I want my colleagues on the panel to introduce themselves. And then we're going to do 2 things, really. We are going to offer a bit of a readout of some work that we had done together, answering the big question that actually we've all been wrestling with throughout the course of this morning. And we know, given the kind of the span and character of colleagues in the room, that this is something that I know we're all wrestling with day by day. Back in our home lives and in the places where we work and live as well. And the big question that we were looking to try and articulate a response to is what does a health creating neighbourhood look like? How's it constructed and how does it operate? And how would we describe that if we got it running in a really fabulous way? So, into the introductions first. So I'm Warren Heppolette. I am, as with effect from a week yesterday, I am now the Director for the Prevention Demonstrator for Greater Manchester. We don't have enough time for me to describe what that is, so I think it's probably best to let your imaginations run riot with what my job is, because you'll be in exactly the same place as I am then in understanding that role. So I'm going to go to the panel and just ask them to introduce themselves, if that's all right. I'll start with you, Matt.
My name's Matt Brayshaw. I've done lots of things in the community in my life. I guess one of the things which has had sort of most significance for today is I used to work for a service that's all over England. In Birmingham, it's liaison and diversion service, which is where people who got arrested were sort of triaged, and then we supported people in the community and not to go into prison. And I guess the reason it's so significant is that I saw people get well and lead better lives, some with the NHS and some without. And then I became really not well a couple of years after leaving that service, and so I did the same as well. So I'm linked with lots of community projects, both helping with them, but also being a participant. So there we go.
Hi, I'm Claire Astbury. I'm Head of Housing Strategy and Development at Luton Council, and I'm off the back of a 30-year career in housing. And it's all about where you live, folks. No, it's not all about where you live, but it's partly about that.
I'm Moneeza Iqbal. I'm Director of Integration and Provider Collaboration for Oldham Integrated Care Partnership, which is here in Greater Manchester, part of the ICB. So I'm kind of the boring NHS management type person on the panel. But yeah, maybe not boring. But also in my spare time, I volunteer for an organisation that supports care leavers, which is probably where I learn a lot more than I do in my day job.
Thank you. Hi, everyone. I'm Kavita. I'm a GP in Tower Hamlets and also the NEL-ICB Clinical Lead for Personalised Care and Training Hub Clinical Lead as well. Previously been a PCN Exec Director, looking after a population in a very deprived area of North East London, and also a Health Creation Alliance member for many years. So really great to be here. Thank you.
Brilliant. Thanks, everyone. So what we're going to do is I'm going to offer a bit of a 5-minute readout with a couple of slides that just channels the kind of the headlines of the work that we and some other colleagues that are represented in the room here as well did as a cross-sector collaborative working with the Health Creation Alliance. And then I'm going to invite a few sort of reflections based not only on the work that we did, but the discussions and contributions that we've heard in participating through the event so far today. Oops, I've gone too far, haven't I? Oh, I've missed a slide. I think I'm going to start with almost the slide that was in my head at the start, because one of the things that I think, and we've definitely heard this today, is that in getting into a progressive conversation about what does a health creating neighbourhood look like, we've got to be kind of really upfront and overt about challenging the way that language gets distorted or co-opted and starts to lose its original meaning. And the things that we kind of surfaced was that even the word health means different things to different people. So what we were quite keen on was health in its truest sense, which is a total state of physical, mental and social well-being. So we were leaning into the kind of the World Health Organization definition of that. And the reason why that felt important to us is that health, even in the NHS, is often seen just as a sector and described as a sector, not as a state of being and a state of well-being in particular. So it feels like before we can get into a conversation about health creation and neighbourhood health, it's really important that we own the language around what we mean by health, so that we can, I think, kind of challenge and to some degree kind of frustrate what might be the habits of people thinking when they talk about neighbourhood health, you are talking about neighbourhood health services, and we are deliberately not. So the bits that we tried to make sense of, and as you might imagine, the fact that this isn't in a hierarchical triangle was quite a considered act of design as well. We were all limited by our PowerPoint capabilities, but we were smart enough to know that this can't look like a hierarchical slide. But some of the kind of the big components and objectives and aims of neighbourhood health and the importance of starting with purpose here really kind of matters. The things that kind of ran to the front of our minds were health creation, and I think this is in particular, this feels like it's been the dominant theme this morning to me, I think, and because I think that is about, it is about community agency, it is about power shift, I think it is about democratisation and true accountability of public services. I think we bandy words like accountability around. I think sometimes we use them as a shield. So if we feel that we're accountable, that's a reason for us designing services in the way that helps us manage that accountability. But it's not accountability to a population. So the business of health creation, of agency in communities and with residents, of strengths-based working and understanding what that does to unlock the capacity in the system, not to ask us to share power, but not to ask us to cede power, but actually to share power and create more from what we have. The second thing is getting deeper into the word about the word of prevention and what we mean by prevention. So for us, that was as much related to social injustice and embedded discrimination as it was to addressing the social determinants of health and offering kind of preventative, formal and statutory services. And then in the way that we think about offering care in neighbourhoods and understanding the breadth of that. And the reason why we wrestled with this in the form of triangle, because there is no kind of stopping point and there is no boundary between these three elements. And we've reflected that it can't just be cohorts and services. There has to be a degree of kind of fluidity, because very often the key to addressing a long-standing health problem is actually addressing and supporting somebody to work through a long-standing social problem. So there is a necessary kind of fluidity to the way that we describe this. And then into, and I'm afraid I'm going to use the word, although it upsets Kavita as a GP on the panel. We described this as the Petri dish. And we thought that was interesting and helpful because it was about live cultures when all of the participants and contributors to neighbourhood health started to come together. It freaked Kavita out because she was seeing it as, I don't know, something nasty that was growing in the gloom. And we had maybe a more kind of asset and strengths based view on that. So I think here lie quite a lot of the challenges that we've started to explore through the day so far. I think the business of cross-sector working, what that means for going a bit further than just co-locating teams and starting to address the culture of public services and the patterns of working with communities. What it means around the what does it mean for trust in delivery and trust with communities? What does it mean for changing the way that we commission? And I think there was. I really enjoyed Manal's session before lunch, and I think she might have had to leave, but it's really good that colleagues from Manal's team are here with us now, because I was really heartened by the boldness of sticking with the mission, attaching ourselves to the outcomes that we're trying to move, and recognising that this will change the way that money flows around the system, and that we've got to be able to unlock the means of changing the flow of money around the system, because the proportions have to change if we are going to be able to address the dose of preventative activity that we're describing. And significantly, I think the biggest question for us, and the one where I feel like we are least close to answering the question, is the question about multi-sector governance and equity of voice and the genuine pooling of sovereignty in the allocation of public resource and the design of public services. I think we say that a lot, but I don't think we found many of the right mechanisms that I think would start to meet the bar of deliberative democracy or participatory budgeting. I think we should be thinking in those terms, and these were the the debates that we'd started to get into in designing this representation. So. It's a model that is all in. It's a model that does start to affect the way that national organisations facilitate and support place-based working and different forms of democracy and participation. And I think importantly, and I'm going to move to the panel now, if that's okay. Importantly, I think this has been reinforced through the morning. I think significantly we've learned quite a lot. And we were the more detailed version of these slides starts to unpack and describe the what good looks like in each of these phases of what we mean by a health creating neighbourhood. But I think we've added to that through the course of the conversations so far. So I think I'm going to go to you first, Kavita, and I'll work my way back if that's all right. And what we did was that each of our panel members were part of the breakouts earlier in the morning, and we tried to put them in places where they might be less comfortable. So not put them in a home room. So there was a bit more discovery and a bit more agile learning that we were taking the opportunity to do. But I'll go to you first, Kavita, with any reflections on the work that we did together or how that's been developed from today's sessions.
Yeah, brilliant. Thank you, Warren. I think one of the things that really struck me is we talk about cross-sector working, and I like to think that I'm fairly okay with that actually, and I'm quite experienced with that. But I did say to Meron that I have very limited knowledge in housing. And what I really thought about today when I attended the session on health creating homes and places is we're really on a journey still. There's so much more to learn from each other. And I really wish that there'd been more health people in that session today, because I learned so much. And we know this on a visceral level. I just saw a patient the other day. Her HbA1c was 140. For people who don't know, that's really high. And it wasn't her diabetes. It wasn't because she didn't want to get better, but it was because of her housing situation, and it was because of the mold. And this is a story that we hear time and time again. So until we want to tackle the long-term conditions that Minal talked about earlier on, we really have to tackle those causes of the causes. And it just struck me there also, we heard from HLM Architects and Home Group and Peabody as well, is that, we have 5,000 to 7,000 homes being built that are suitable for retirement living, and we need about 30,000 a year. And it struck me as a GP, I know light bulb moment, it does fall a bit late for us GPs sometimes, it's like, oh my gosh, we never actually ask, do you want to move into retirement living now? We always do the advanced care planning, but we don't really ask those questions. And then it started striking me also is at a piece, we're kind of working in primary care networks, which are kind of, morphing into these neighbourhoods or parallel neighbourhoods. And at a PCN and neighbourhood levels, do we have housing associations voiced there around the table? Do you even know who your housing associations are in your area? And I think these are really important questions for health to be thinking about. And we know that prevention of falls, for example, is one of the highest returns on investment. And to get people into a safe environment will save the health economy so much money. And then even from an ICB and place perspective is do we have those strategic partnerships where we're really thinking about our patients on their life course, as a patient, not as a condition or multimorbidity, but where do you want to live now? Where would your next place of living want to be look like? And what is your life look like? And those were the things that really struck me that I thought, I don't think I knew it all, but I thought I had quite a good foundation of knowledge, and actually there's so much more to learn. Thank you.
Brilliant. Thanks, Kavita. So I think that's something about the power and validity of a simple step of almost introducing public services to each other, and then positioning that introduction in the context of how do you maximise the health potential of a population, who has a contribution to make, and how do you start unlocking that contribution. And this is a kind of growth in capacity and resource that we sometimes turn our face away from. So I think that's a really helpful reflection of Peter. Thanks for that. I'm going to go next to Moneeza and ask you, which uncomfortable room did we put you in?
I didn't think it would be the uncomfortable room. It was the room of revelations, which was the social care room. So, maybe a shame Kavita and I are talking after each other, both NHS, but I think I thought I had an understanding of social care, but there were several nuggets that really struck home with me. And I think, it builds on what Kavita said, which is the relevance of the Petri dish is the conversations people have at all levels to understand each other. So whether we can break the system down, move money around, the minimum we can do is the quality of the conversation. So there were several bits that struck, and the first one was that the neighbourhood health stuff, unfortunately the NHS dominates this space because it's a vote winner or a vote loser. It's where a lot of money is spent. It struck me after hearing George talk that it could easily be described as the neighbourhood social care. And it reminded me of the power of storytelling as well in this arena, because it goes back to the talk earlier on wellness. Similarly, could it be a neighbourhood wellness service? But the learning for me similarly was, I think, health, again, not understanding truly what social care is. So I grew up with a mum who's a health visitor who constantly complained about the social workers because they never understood each other. The nuggets that I have to say will really stay with me from listening to George and the other speakers in the social care stuff, and I'll quote these back at you because I think they're fantastic. that social care is supporting people to live the lives they want to live. So I think we think of frail older people, we think of people with learning disabilities stuck at home, we think of people in crisis, and we're not thinking of I am living the life I want to live, how are we supporting others to live the life they want to live. I think the other nugget was every person who shakes hands or hugs somebody is delivering social care. That again feels like it's at the heart of the health creation stuff, because it's literally the personal connections. And I think the final bit in those 3 quotes is, we're frightened to ask people to dream, because basically we're scared that they're going to say, actually my dream is a holiday on a tropical island, or is for you to buy me a 4x4 Land Rover. And actually probably what their dream is to be able to leave the house independently and go to the cinema or whatever that is. So I think that there was for me, a big thing about, and Manal's presentation was fantastic, but I felt really grounded in what neighbourhood health and health creation means on a really, really individual basis, and on a really simple basis, which is literally just, how am I living a life I want to live? Really helpful stuff from Nick, from the Community Catalysts, and some really helpful things he shared about similarly building on that, which was the understanding the vision of a good life, which was, and again, roots this back into the person and not the system, and the system almost, and statutory sector services come last, which is what does somebody already have in place? What support can they draw upon? And then after those things are considered, what role do services around them play? Those feel like they kind of go back to our neighbourhood health concept. We talked to Warren before this because we wanted to say, what's our breakthrough? What's the thing that's really going to make this happen? Putting money aside and the government unlocking a payment mechanism, I think it's probably the quality of conversations, and in particular, it's probably beyond this room and beyond the converted. It's probably using those nuggets of stories to those who aren't converted yet.
Brilliant. Thanks, Moneeza. And I had the benefit of being in the same session, and I think the power of the fact that actually we are all in the business of social care the minute that we're into any kind of relational activity, and the simplicity of this being a human-to-human endeavour based on love is something that we really, really need to hang on to, because very often we get overwhelmed with the change in developing a neighbourhood health system, and it being contractual and it being transactional, and we'll lose it the minute that we start to kind of preference that kind of shift and lose the humanity of what we're reaching for here. So, Claire.
Hi, yeah, so I was in the neighbourhood health, actually, right on the button stuff, neighbourhood health systems, and we heard some really great examples of things that people were doing on the ground, and from a couple of areas that are in this sort of first wave of places. And actually, one of the things that really struck me about what Manal was saying was that they sort of opened up for a first wave sort of bids, and like 80-odd% of the country wanted to be in it. And that says to me that maybe we just do it. I don't know. Like that seems. It seems like, if everyone's already wants to do it, why are we limiting the number of people who get to do it? I don't know. I don't know enough yet about how that works, presumably. Anyway, some really inspiring stuff. What really came through to me from the places where this is working well is it's rooted in understanding the place and the people that you're serving, and recognising that health services are a part of a whole community well-being picture. I think this was really well presented, and I think it was from, I want to say, Runcorn, in a sort of diagram about all these sort of building blocks, of which there were about, 12 or 14, only one of which was around health services. And I think that's about being honest about where those health services sit in the whole piece. I would say that because that's the kind of area that I'm coming in from, but I think it means more when it's coming in from the health perspective as well. And absolutely what came across again and again was listening listening to people, helping people co-create and design the services that they need, be brave and doing them and acting, doing something, working with the people who want to do it and just doing it. And then in the delivery of that stuff, what came through to me there was being consistent in the leadership and the guidance and having a sort of single out, agreed shared outcomes and keeping the same people again and again, keep it going, keep the flame burning. So I think that consistency of ownership and leadership across the piece and listening to the right voices is really important. Being available, removing barriers was a really strong piece from the work in London, and it was, just show up and let people come and talk to a doctor. It's like, okay, absolutely. Removing barriers, no forms, no kind of eligibility checks, just be available. And that actually, from a GP perspective, they were talking about, joy, losing the joy from knowing that they can help people and see the outcome of helping people. And I think this is true for people across loads of different public services and voluntary services and so on. There's a mission there that people want to see that it's made a difference. And you help people to see that and track that. You create joy in the people delivering the services, and it creates more joy for the people who are part of the receiving those services as well. And joy is a very important part of wellbeing. So I'll leave that there.
Brilliant, thanks, Claire. And there's an important role here for. Thank you. That was worth it, I think. Important role here for the Alliance itself, because I do think there is something in if this is a movement, the stories that we tell are going to be part of the fuel that helps the process of spread and excitement. And I think we probably need to give a bit more thought to what do the stories look like and how do we articulate them. So I've deliberately waited to the final contribution from Matt, because my big kind of takeaway from this is that I think the community agency, power shift, democratisation, rethinking accountability is going to be part of the special sauce that will either make or break this as an endeavour, and demonstrating that actually there is a different deal to be done with residents and communities, and that we need to lean into it. So I'd be really keen on your final reflections, Matt.
Well, it was absolutely fantastic. And by the way, I chose that kind of like out of the four, and it happened to be the one I was supposed to go to, so that worked out quite nicely. I was having a bit of a scramble actually halfway through that. One of the things that I really believe in that I thought was fantastically highlighted in the projects from Manchester, I guess number one is the teamwork between different organisations. That takes lots and lots of effort and openness and courage and risk and things like that. And the other thing connected with it is, and again back to my days with liaison and diversion and different workers working together in a really effective way, was the idea of specialisms. So we have this in health, don't we, where we say this consultant, quite rightly, thank goodness, does cardio, this consultant does orthopaedic and stuff like that. When I worked in liaison and diversion, it was like the doctor does the, do you know what I mean, sees if someone needs to be sectioned. The nurses almost a lot did the clinical risk, so when we went out and checked everything was okay. But the peer mentors, they were specialists as well, do you know what I mean? So they were always called down to the police station to get people to engage in services, and it was an absolute specialist, do you know what I mean? It wasn't like they were band 3 or band 4 or anything like that. People still get paid differently, but actually we saw everything as a specialism. So I love that, and that came out in the project in Manchester really well, including Mac Bull, the PM as well, which was it the project manager? Sorry, it was the project manager. I'm a sort of football fan. It almost seemed like you were. There's like number 10 in a floating role in football. Do you know that? Who's just they're not they're doing loads, but not quite somewhere. They're linking it all together, and that's what it felt you were doing really, really well. Yeah, and so and the value of lived experience. Obviously, I don't know whether people know, it's from mental health. There's a guy who passed away actually earlier this week called Ron Coleman, and he was very much involved in sort of the Hearing Voices network in Manchester and then internationally. And I'd go away and have a read about him, because for me, he every single day, whenever I get annoyed by anything, it's usually because I've read a few of Ron's books, and he talked about lived experience. But one of the things he used to say at talks was, people with community voices not looking to take over nurses' jobs or doctors' jobs. We still really need you. All we're asking is to do one or two things a bit differently. And I think that's what I got as well from this morning about leading change as well, and being part of the change with colleagues in the health service.
Brilliant. Thanks, Matt. So total football from Matt Brule and Stacey in North Manchester, I think. Okay, I think we might be. Are we up on time for our bit? So what I wanted to do was I think for the next stage of this, we've started to kind of craft and articulate what we think this means and capture it in a way that made sense to us with the limited work that we did as a cross-sector team, and we're keen to take the outputs today. I think we could do an extraordinary version of this after today, and we'll be circulating that with the outputs from the summit, if that's all right, Merrim.
Can you ask people not to put it on LinkedIn, because we will be publishing it in a couple of weeks' time?
So Merrin's just said, when you get it, don't put it on LinkedIn, because we'll be publishing it in a couple of weeks' time. So let's not. Let's just be part of the drum roll that leads to that, rather than taking it off. But would you just be able to join me in thanking our panel and as keynote listeners? Thank you.
Hello. God, the wonders of science fiction. You're all speaking to a disembodied head from my comfortable study to your corporate space. How you doing, people? You'd have to say anything, because I won't hear you anyway. But okay, so let's go. I'm sorry I can't be there, but I'm also glad I can't be there, because I'm fighting off my annual bouts of chest infections. So I'm glad I'm at home. I always try to embarrass Merrin by saying nice things about her, and I can see her cringing, and as I say to her that she's a visionary, and the difficulty with being a visionary is that, as Merrin will no doubt tell you, is that it's really hard for other people to see your vision if they're so busy busying themselves, usually with not a vision, if you see what I mean. So I'm here because Merrin asked me, basically. And I'm no doubt, I hope I'm right, there's some energy in the room, the sense that something that's been long talked about is finally within grasp, within reach, something like that. And no doubt every story you've heard today says the same thing. Health isn't delivered, it's created. It's created through connection, trust, and the power people have to act on what matters in their own lives. Now, I've been asked to reflect on the prospects of the 10-year health plan. Remember that? And to some extent, the English Devolution and Community Empowerment Bill. And really, the question is will they strengthen that local power and to create health, or will they drown it in process? And we love process, particularly in the NHS. Process is a bit like Hogwarts, the stairs that don't go anywhere, that's process. The rooms that don't have anything in them but smell of magic, that's also process. There are some rooms in which the process is actually that are full of stuff, and that's where the process has actually been connected to a clear intention. But that's the question. Will these things strengthen local power to create health, or will they drown it in process? And my honest answer is that they could be transformational, but only if we use them to shift power, not just policy. So I want to talk about the current situation, talk about pragmatic reality for a few minutes. And let's start where system leaders are living right now. Local NHS and care leaders are operating under incredible pressure at the moment. They're balancing day-to-day delivery with long-term ambitions of the plan. And they're having to be both pragmatic, asking how every pound, every partnership can have the biggest possible impact for their population. And yet they're also labouring under the 50% cuts, the demise of NHS England, the pressure on the waiting lists, the old sort of meet your numbers or die culture. And yet the 10-year plan is genuinely supportive of the poorest communities. It recognises that health inequity is the defining challenge of our time. And it was hard fought for to get that in. But prevention cannot be delivered by the NHS alone. It must be multi-sectoral, with action across local government, industry, and the voluntary community and social enterprise sector. Some of you may know I'm the chair of Social Enterprise UK. And I think in saying what I've just said, I'm really talking about leadership, and that's the crucial enabler at every level. At the macro level, national government needs to set the direction and create the incentives. At the meso level, the regional systems and ICBs need to be aligning resources. And at the micro, neighbourhoods designing solutions with their communities. And the Confed's own health inequalities toolkit puts it very simply: leadership is the #1 enabler of equity in this regard. Let me talk about prevention as the new principle. The 10-year plan signals a vital shift from reactive care to proactive prevention. And that is a huge cultural change within which clarity matters. We need clearer guidance on the balance between primary and secondary prevention, how it will be prioritised, funded, and evaluated. There are enablers that can make this real. A new operating model with NHS England and the DHSC now merging, not now merged, but merging, and ICBs empowered as genuine strategic commissioners. And just a word about commissioning, and some of you have heard me say this before. Commissioning is the means by which you understand the needs of an individual and/or a community, such that you can build a platform for procurement, contracting, and purchasing, not the other way around. System leadership. So we need a new operating model, as I've said, that should be created between NHS England and DHSC, and ICBs that are empowered to genuine do strategic commissioning as I've defined it. System leadership that defines what each system is trying to prevent and how success will be measured. And neighbourhoods taking centre stage, delivering action on the social, economic and commercial determinants of health. And it seems to me that data, that's useful information, not just data on its own, is key, not just to counter activity, but to target inequality and inequity, to design outreach where it's most needed, and to demonstrate impact. We've got to get the funding rhythm right, balancing short-term flexibility with long-term commitment. And preventative interventions take time to show returns. We can't keep judging success by the length of a political cycle. I guess that's why it's called a 10-year plan. That's 2 political cycles. We also need to work across sectors, science, civil society, and place. The cross-sector collaboration is already proving its worth. NHS partnerships with the research-based life sciences industry have delivered breakthroughs that prevent illness before it starts. And the VSSC sector brings the local intelligence, the trust, and the reach that systems cannot replicate. And in that, there's some of the examples around vaccine denial and vaccine hesitancy, where science and the local community engagement has actually increased vaccination rates, are an example of what I speak. Half of what determines health lies outside the clinic, you know that, in housing, work, income, and the built environment. That means prevention must be cross-government, multidisciplinary, and multi-sectoral. And without transforming relationships with communities, we risk widening the very inequalities we try to close. And one of the things I'm worried about is neighbourhood health becomes a kind of tick box exercise dictated by the top, as opposed to created from the bottom, to coin the phrase. Let's be clear, without real community agency, a neighbourhood health service will be little more than a rebrand of overstretched resources. What makes it different is when local people own the change. Let me say a word about health economics and the NHS as an anchor, because I think it's important. The anchor concept, the NHS as a force for economic and social prosperity, put simply, there is no wealth without health, is one of the best developments in recent years. It's in the 10-year plan. NHS employment should be a driver of economic mobility. Government, business and civil society must come together behind our plan, not just for the NHS, but for our national health. That's progress, but it's not enough. We must go further, nationally and locally, to make the NHS a true partner in economic renewal. Many ICB leaders tell us that the fourth purpose of ICSs, supporting broad social and economic development, gives them permission to reach beyond the hospital walls and focus on what makes us healthy, not just on what repairs us. And if you look at economic inactivity, 2.8 million people are out of work because of long-term sickness. If we don't prevent people in work from becoming sick, we'll never meet the government's goal of 80% employment or build a thriving economy. The new health and growth accelerators, some of which are in the North East, Cumbria, South Yorkshire and West Yorkshire, are tackling this head on, testing ways to help people stay well, stay in work and live independently. And that's prevention in action, and it's culture change. To back this up, the Confed has launched the NHS Work and Health Network, national space for shared learning and collaboration. So we need to align health and devolution. Government's clear, devolution is its chosen path to an inclusive economy and reform public services. As standardised government models evolve, we're seeing far greater alignment across public services, and that should empower local leaders to act for their communities. But alignment works only if ICBs and mayors succeed together. Their futures are intertwined, just as health and prosperity are intertwined. And that's why the Confed and I are working directly with combined authorities and mayors, helping them shape their health role, because they hold many of the levers of what truly keeps us healthy: housing, transport, skills, environment. Of course, the key questions that remain: how much scrutiny and influence should mayors have over health decisions? How do we ensure accountability without re-centralising power? Those are conversations that are now underway with DHSC, LGA and others, and they matter deeply. Our 2024, the NHS Confederation 2024 report set out the principles for success: focus on people and places where they live and work, support populations to improve their own health, recognise that everything, economy, environment, education, has a health impact. And this is also at the heart of government's public service reform agenda, which is trialling new ways to integrate services around communities most in need. Prevention sits at its core. It's a return in spirit to some of the total place pilots that happened a generation ago, but this time with the learning, hopefully, to make it stick. Neighbourhood health cannot be NHS only. It must cede power to local partners so that every neighbourhood becomes a thriving place. So, what are the prospects? They depend entirely on whether we have the courage to turn good plans into shared power. If we trust local leaders to lead, if we invest in prevention for the long term, if we measure success by what communities can do together, then the 10-year plan and the devolution bill can be remembered as the moment we stopped delivering health and started creating it. Because this isn't just health policy, it's national renewal. It's about a country that believes in the capacity of its people, and a country where the wealth of communities becomes the well-being of the nation. We've got no choice but to try and build that country together.
How is this not just another centrist reform that is genuinely going to achieve system change? What gives you hope that this is genuinely going to make a difference? And do you see political will to actually enable that difference to occur?
Well, everything that I've said has been about hope. I've indicated why I think it's possible, but I haven't said it's certain. There's political will, but system inertia. People don't like change. That's just a fact. People in this room, well, some people like change, but few people like it done to them, or even with them for that matter. And the NHS is one of the most resistant institutions to make change. And it generally avoids change by adopting language but never changing behaviour. Having said that, I think the work that we're doing with the ICB mayors, some of the examples that I've given you about what's actually happening, the health and growth accelerators, for example, some of the work that's being done at neighbourhood level, I think they are, if you look at what's happening in Manchester, for instance, they are green shoots, and I've visited them, so I know that they're working. They are more than just green shoots. They're examples of what could be grown, what could be scaled, to use that term. And so I'm more hopeful than I've been for a long time. But hope alone isn't enough. And I'm an optimistic person, right? I'm far too lucky to be pessimistic, as I'm fond of saying. As is everybody in this room, actually, to be honest.
I appreciate the answer and the candid nature of it. Thanks, Victor. Now, we've got another question here. And if you can't hear it, I'll convey them to you.
Okay.
Please.
Hello, Victor. My name is David. You mentioned leadership. I've had a conversation with a couple of people about leadership. Can you hear okay?
I can't hear you, but it's going to be translated, so speak.
Okay. I'm being invited for thank you very much.
Be pithy.
Be pithy.
Hello.
But don't take it, yeah. I've had a couple of conversations with people about leadership, and really my concern is, how does leadership challenge itself to meet those requirements?
Yeah. Okay. Do you want me to answer these questions one at a time? Because I'm happy to. Okay. So the thing about all the examples I've given you involved a shift in leadership. When I said the NHS resists change by adopting language but not changing behaviour, that's what I meant. I'm talking about leaders, basically, because in most organisations that I've worked with, this is true based on the work of a chap called Barry Osher. But anyway, the people at the top understand about 20% of what's going on, the people in the middle about 30%, but the people at the bottom facing the people, they understand the remaining 50%. And the leadership that works, and we don't talk about leadership enough in the NHS as a practice for an organisation its size. In the private sector, that's all they would be talking about: leadership, practice, leadership design, the kinds of leaders they need. That's not happening enough. But the sort of leaders that we need in the NHS are system leaders, people who can see beyond the boundaries of their own organisation and can see the condition of the system as a system and their role personally in it, their role organisationally in it, and what needs to shift in order to create a healthy system. Now, we've got some of those. I always note that Rob Webster in West Yorkshire is one of them. There are others around, but we haven't got enough of them because it's not talked about enough and it's not supported enough as a direction of leadership. So the answer to your question is, I don't think we challenge leadership enough, and I don't think leadership challenges itself enough in the NHS beyond the people that are doing the kind of system leadership that's necessary to get to where I've just described, and that's a weakness.
Hi, Victor. Toby Eccles here from Social Finance. I guess.
Hello, Toby.
Hiya. Good to see you. A couple of thoughts. One is there are to enable some of the change. When we've listened to examples earlier today, as you say, change is unpopular, and it's quite often unpopular in the populace as well. So if we're going to sustain a higher preventative, a higher community piece, that probably means reducing acute. And actually, as we all know, taking any acute out is typically a deeply unpopular decision. But we had Steve Taylor from Rochdale giving a fantastic example of where everyone now loves it, but they hated it when they had a go. So do you see the system leadership for that? That's the first part. The second piece, you mentioned bureaucracy. The three nightmare horsemen of finance, procurement and legal. Is the centre going to be enabling, or can the centre be supported to be enabling around those rather than trying to own the change itself?
Well, first of all, so basically straightforward answer. Nobody wants to go to hospital. Put your hands up if you want to go to hospital. Yeah, it's not very popular. So the question isn't that hospitals are popular, it's that that's what people think is the NHS. And they think that's the NHS, but because in the absence of another vision in which they can see themselves getting the health that they need, they will go with what they've got, and what's more, they'll fight for it. It's not difficult. If you present people with a vision, positive vision of what could be and what should be and what can be, they will go with it. Most change fails in the NHS, not because it's not possible or because the public don't want it because they're in love with hospitals. It fails because we fail to present a credible vision and communicate it to the people that need it the most. Nobody wants to go to a hospital. And I suspect that's what, you stay in contact with them, and I suspect that's what Steve has done in Rochdale, and that's why people love it. Nobody wants to go to a hospital. They don't want to die there, they don't want to go there. That deals with that. I think on the bureaucracy front, look, we have a government that's aligned with much of what we are trying to do. And as I've said, it's stated in the health plan. We need to take that seriously. I think what the government needs and what the NHS needs and will need to do is, again, what I said, the incentives, the financial incentives in particular, need to be changed to reward the right behaviours. You know, that's just a fact. If you have an activity-based system in which the acute is paid to do activity, don't be surprised if that's what you get. You know, the system is perfectly designed to get the results that we get. So we need to change the incentives. We need to think about outcomes. We need to think about engagement. We need to think about, you know, measuring things like positive value transfer. You know, how many places do people need to go to get the healthcare that they need? You know, all that's expensive. So there are, we can measure the reduction in inequity, and I use the word inequity deliberately, and in inequality, and we can incentivize those so they become prevention levers. So it's possible, and you know, that's what we should do. I don't think the three horsemen of the apocalypse, as you so eloquently put them, they're just tools. Finance is a tool, procurement's a tool, and legal's a tool. You can do with them pretty much what's needed. It's all about interpretation and the frameworks and the incentives. I shall stop there.
Thank you, Victor. One more question, one quick one from Hope.
Hi, Victor. I'm Hope. Nice to meet you.
Hello,
I will
Hope.
try and be quick. We have awareness, we have information. The people who want to help are constantly forced to study suffering instead of actively ending it. There are so many angles and inquiries of the same information, millions spent on data saying what people already know. For those without, life is hard. I see so much waste every day. If every report and inquiry says the same thing, the problem is a lack of accountability and political will. What steps are there for us, me personally, and the people in this room that have that kind of agency for us to do to change that? Thank you.
Brilliant.
Well, you know, I'm one of these people. I don't like revolutions. The young often, although I'm surprised that this generation are asking for, often ask for revolution. The current state of politics suggests that there are some people asking for revolutions that frankly terrify me. I'm all for evolution, and anything worth doing is worth doing well, and that often is slower than we would all like. So there's something about taking responsibility for the fact that change happens at the pace that people and communities will partner, work with each other. And I I think you're right to be impatient, but you're not right to rush the process. I think that's just something we have to understand and work with. And that, oddly enough, is a kind of, the more you understand that, the faster you go. See what I mean? So that first thing to say. The second thing is, yeah, there's loads of stuff that, you know, yeah, there is a lack of accountability. You're speaking to the person who set up the Race and Health Observatory because of the lack of accountability for the health outcomes for people who are various shades of me. So I know of what you speak. The thing to do with anger and impatience is to do something as opposed to do nothing. You turn it into a creative force. The NHS was built by people who were less educated and certainly less wealthy than most people. Well, everyone in that room. And the stories of people in Tredegar creating their own health and social care system, all contributing to it, free at the point of charge. And Nye Bevan, that's the picture of the guy who's it's a tea towel on my radiator right there, just to show. Who was born in Tredegar, went back there for a visit, and he was shown this scheme that in which everybody contributed and everybody got healthcare free at the point of access, and that empowered him because he didn't know quite what he was going to do with the task given to him. And he made a speech. He said, "I'm going to Tredegarise healthcare in this country," and that's how we got the NHS. So the possibility of change from anywhere but the top is absolutely there at the bottom. That's how it works, right? So you as an individual need to understand your own authority and use it to the max. You as a community need to build relationships that form that are equitable and help you use the knowledge that you've got of your own community to influence what happens. And you as leaders need to use your knowledge and authority and leadership to make the change. And one of the things that I notice when I talk to leaders in the NHS and the healthcare system is the fact that they often don't use the authority that they've got to its maximum. They often complain about things they can do nothing about. They often don't use the influence to its capacity, but they certainly don't use the authority given to them to its capacity as well. So as an individual, that's what you need to be doing. I don't know whether that's helpful, but it's what I've got.